sincere thanks to the organizers and my special thanks to Dr. Rangareddy Garu for giving me this opportunity to be amongst you. Dr. Rangareddy Garu has given me a call about 2 weeks ago, and he wanted me to talk on hypertension. Well, I think it's just a notion for the benefit of the budding postgraduates and then the undergraduates who are going to be the physicians of this century. What I'm trying to do is just trying to pick up a few drops from this ocean and evolve few steps as to how to prevent, because that is the central so-called idea or theme of today's program. The earlier topic, as Dr. Rangareddy Garu has elaborated, was mostly on the communicable diseases, a facet of communicable diseases rather, antibiotics. Now I would be dealing more with the non-communicable diseases, the facet number 2, as Dr. Ramkishanji has pointed it out. This is something which was a so-called mini pandemic during the later part of the 20th century, and it continues to be a mini pandemic in the 21st century, thanks to the occultation and the changing lifestyles having an impact, like development of diabetes, obesity, dyslipidemia, various other things. So it has become an important element of the lifestyle diseases. Hypertension per se is mostly polygenic inheritance. Let's start with India. We now have 22 crore population. Mind you, the undergraduates, please wake up. 22 crore population are hypertensives. And as Dr. Sridhar, my senior colleague cardiologist, has made it very clear, only 12% are under control. So you as physicians of the future have got an ominous responsibility of managing effectively the so-called dreaded disease. The worldwide statistics are even more greater. 1 billion people are being diagnosed as hypertensives per year, out of which 9.4 million deaths are occurring per year. The prevalence is more in people who are more than 60 years, and if you take the US statistics, 65.4% people are hypertensives, and it is predominantly more in blacks and non-Hispanics, Asians. So all of us, we are at risk. What is this hypertension? To recapitulate the definition for the benefit of the undergraduates, so normal blood pressures is around 120, less than that, and less than 80 millimeters of diastolic blood pressures. There was an element of a so-called statement which lasted for about 5 to 7 years as per the JNC 7 guidelines. Pre-hypertensives are anywhere between 120 to 129 systolic and less than 80 millimeters of mercury diastolic. Stage 1 hypertension is between 130 and 139 systolic and 80 to 89 diastolic. Stage 2, mind you, this is something that's beginning to become rather serious or dreadful, is anywhere between more than 140 and more than 90 diastolic. Mind you, this reading should be based on 2 or more seated recordings in 2 separate official visits or office visits. These days, there is a facility. In fact, there are lots of bodies, both from the pharmaceutical companies, they have come forward, and many bodies have laid down specific instructions to make best possible use of continuous ambulatory blood pressure monitoring, and they have even provided facilities to measure home blood pressure monitorings. This is very, very practical and quite useful in judging the patient. Why? I'm coming to that in my next slides. The nocturnal dip attenuation. The blood pressure usually drops in the evening or towards night, and then there is an early morning surge thanks to the steroids and various other hormones which give rise to this rise. So this is the physiological, as well as sometimes if it is extended, it becomes pathological. Any attenuation of this nocturnal dip followed by an early morning surge is extremely important, and it is a precursor for development of blood pressures and the ensuing CV events, the cardiovascular events. See, why is it important to know something about the mechanisms of hypertension? It is definitely important because various treatment options are available for us now these days. You have the pharmacological elements, the non-pharmacological elements play a very, very important role in the control of hypertension also. So, what are the mechanisms by which the blood pressure shoots up in an individual? Intravascular volumes, mainly the cardiac output, the vascular resistance, which is measured by the peripheral arterial resistance, the various hormones, the parasympathetic and sympathetic pulse, noradrenaline, then you have the other hormones which indirectly contribute to the development of hypertension. The renin, angiotensin, aldosterone system, and lastly the immune mechanisms, various inflammatory markers, the CRP, the various oxidative stress is equally important in building up the blood pressures. This has been notified or seen, observed in various autoimmune diseases like SLEs, RAs, where you have a disarray of autoantibodies and most important inflammatory markers like CRP. So this makes the treatment options quite complicated and intricate. What happens if the blood pressure goes up? As Dr. Sridhar has already elaborated, it is the end organ failure. The patient may have CAD, MIs, congestive cardiac failures, various types of tachybrary arrhythmias. When it comes to brain, you have ischemic and hemorrhagic strokes. Kidney also takes the brunt, either acute in the form of acute kidney injury or a CKD, the chronic kidney disease. Then you have the medium-sized blood vessels also getting affected in the form of the peripheral arterial disease. Not to spare the small vessels involving the retina, you have the retinopathies. So, hypertension in fact is a syndrome affecting all the vital organs. We need to classify hypertension because we need to treat. As I was mentioning, the primary or the so-called essential hypertension is mostly polygenic. Inheritance is polygenic. Various genetic factors they contribute. Secondary hypertension, fortunately, is rare, but something which the treatment aspect is totally different. You can have the involvement of kidney giving rise to hypertension, the renovascular hypertension, then you have the adrenal gland getting affected, mostly the Cushing's or the pheochromocytomas involving the adrenal medulla. You have the primary hyperaldosteronism known as Conn syndrome. All these things may give rise to the secondary hypertension. The treatment again, mind you, is different. You need to tackle the primary cause rather than using the antihypertensives blindly. Coarctation of aorta, which is more a congenital disorder, where the aorta gets narrowed down either in the thoracic cavity or in the abdomen, may also give rise to hypertension. Then you have obstructive sleep apnea, which my next speaker is going to elaborate. He is one of the most important entities giving rise to hypertension. You have various types of endocrine abnormalities like the thyroid disorders, the parathyroid disturbances, and the growth hormone disturbances, which can give rise to hypertension. Can I have the silence over there, please? And various medications, mainly the oral contraceptive pills use, the steroid usage, and some of the antidepressants like MAO inhibitors. These are the things which might upset the balance and give rise to high blood pressures. The monogenic hypertension is extremely rare. It is transmitted genetically by a single gene. Mind you, that's extremely rare. There are other terms which are quite often used in the medical terms in the medical colleges. The white coat hypertension, the patient becomes, or you notice as a physician, the blood pressures getting elevated when the patient visits your office. This is seen in 15-20% of the people, but fortunately, the things become normalized when he goes back home. This need not be treated. Masked hypertension is exactly the reverse. The patient's blood pressure is normal at the official visit, but during his home blood pressure monitoring, the blood pressure shoots up. This is something which is dreadful. This you come across in 10 to 30% of the cases, mind you. So that's the reason the home blood pressure monitoring devices are extremely useful to pick up these things and then start managing. You have, of course, the gestational hypertension seen in the pregnancies. Resistant hypertension is a term which is selectively used when more than 4 drugs are being used and still the blood pressures are not under control, and this needs a thorough re-evaluation. The other term which I would like to emphasize is accelerated hypertension, when the blood pressure fails to get controlled despite using 3 drugs. Again, you need to change or adjust the dosing. Malignant hypertension is something which is a medical emergency, which I am going to deal in my next slides. So how are you going to approach the patient with hypertension? As a professor of medicine and a teacher, I would still emphasize, just like Dr. Rangareddy Garu, I would emphasize the need for the HNP, the history and physicals, to be taken, wherein emphasis is given to duration, family history, dietary and psychosocial history, smoking and alcohol consumption, other risk factors. Take into account when you see the patient personally, the body habitus, whether he is obese, medium built or thin built individual. Keep checking the blood pressures in both the arms and one lower limb and both the postures. the lying down posture, the so-called supine posture, and the sitting posture. Look for all the peripheral pulses. This goes without saying. Whether it is 20th century or 21st century, whether you are dealing virtually, which has got its own limitations, but the real world practice of medicine would emphasize the need for having a proper HNP. And lastly, don't forget to see the thyroid, which would indirectly contribute, and the retina. Some of the lab tests would be helpful in eliminating or detecting the secondary hypertensions. I would quickly rattle when it comes to renal, serum creatinine, EGFR, the microscopic urine analysis, and the protein excretion. Look for the serum electrolytes. You may pick up the Conn syndrome. TSH estimation, the thyroid profile would pick up underlying hypo or hyperthyroid states. Metabolic elements like fasting blood sugars, as diabetes is the sister of or the twin of the hypertension in the present day lifestyle diseases, HbA1c and fasting lipids. I would also be interested in having a baseline CBC, EKG and 2D echo just to see the chambers of the heart. Treatment guidelines are very clear. You should target the blood pressures of less than 130 by 80 systolic and diastolic. The exceptions are hardly very few. Acutely ill patients and patients over 80 years. The geriatric populations, be extremely careful, and then you can relax these rules. Treatment, mind you, is highly personalized. It varies from person to person, and it depends upon the associated comorbidities like diabetes, dyslipidemia, hypothyroidism. All these things, they play a very important role in deciding the drugs. You may have a patient with CKD. Again, the medications, the choice of medications is different. The combination of various methods, pharmacological and non-pharmacological methods, forms the mainstay when it comes to the treatment. Quite often, as established during the latest or recent guidelines, you are supposed to use 2 drugs, one in the morning, one in the night, because no drug is effective for more than 24 hours. So we believe in having 2 drugs at a time, or at least 1 drug in the morning and the second drug in the evening to counteract the nocturnal so-called attenuation and the early morning surge. I won't elaborate on drugs because purposefully I am starting the pharmacological ways of managing. I would come to the non-pharmacological ways a little later. Though, as a physician, you are supposed to elaborate the non-pharmacological methods first. When it comes to the pharmacological ways, you have the different class of molecules, diuretics, beta blockers, alpha blockers, the centrally acting drugs like clonidine, alpha-methyl dopa, AC inhibitors, ARBs, which are quite often used these days on the frontline drugs, calcium channel blockers, and next line is the vasodilators, both venous and arterial. You have hydrolysine, sodium nitroprusside, but we reserve them. We don't use it quite often. Something about the device-based treatment, which I'm sure the future postgraduates of medicine would be interested. These are the methods, the carotid baroreceptor activation. You try to use the carotid sinus and then you activate it. This results in the drop of blood pressures. And you also have an endovascular radio frequency ablation of the renal sympathetic nerves. This is where you try to, so you are trying to cut the so-called RAS axis and bring down the blood pressures. This is something which is highly reserved and which is done by the interventional radiologist and the cardiologist for resistant hypertension cases, not for all. Hypertensive emergencies, as I was mentioning, they do require hospitalization. You cannot manage it as an outpatient basis. Drugs, mainly we bank on the intravenous sodium nitroprusside, nicardipine, IV labetalol and nesmolol, predominantly the beta blockers, the fast-acting beta blockers, IV NTG infusions, hydralazine and phentolamine. These are the drugs which are reserved for the hypertensive emergencies. Now I am going to come to the first thing which one has to advocate or preach and practice: the lifestyle modifications. Some of the things which Dr. Sridhar has already highlighted: the weight management, because you are dealing with the so-called panchabhutas, not the panchabhutas of air, water and these things. They are good. Here I am trying to look the other way. They are the villains, the 5 villains: obesity, hypertension, diabetes, dyslipidemia, and of course the smoking and alcohol. So weight management is important. Decreasing the salt intake to less than 2 to 4 grams per day. Having or adopting the DASH type diet. Cutting back on ethanol and nicotine use, which my colleague Dr. Sridhar has elaborated. Acupuncture, this is something which is extremely interesting. It is a Chinese methodology, also brings down the blood pressures. There are various trials. People who are interested, they can go through and you can find them. This brings down the systolic as well as the diastolic blood pressures. Physical activity, any type of physical activity. Mostly if people are not habituated to go to walking, please do it. Brisk walking is more than enough. Walking for at least 35 to 40 minutes per day, 6 days in a week, more than suffices. People who are much more tuned, they can go for aerobics. Others, I would stress, others are equally important. In fact, I am the person who has started off a trial incorporating yoga in managing hypertension. The trial is on with good results, which I am going to stress. The type of yogic kriyas or some of the asanas: dance, music and meditation. Amongst the yogas, how does yoga affect the blood pressures? Alteration of breathing, alteration of the muscular tone, vascular tone. Extremely important in controlling the vascular resistance. The most important thing is the relief of stress. You have various yogas, asanas, balasana, that is the child posture, bending totally and falling asleep. This is a very, very important. You won't find the child, extremely rare to find the blood pressure building up in a child or an infant. Sukhasana, the easy posture which we adopt in the sitting posture. Bhujangasana is the serpent posture which I am going to show. This is the serpent posture which I am trying to practice, and I regularly practice these things at home. Shavasana is the corpse pose. You are lying still just like a corpse. Setu Bandhana asana, this is something like a bridge. And Adho Mukhasana, this is the one, is the mountain pose. People who are dancers, I find young girls, I know some of them could be dancers. So, I'm just projecting the slide, which my wife is a fetal medicine consultant and head of the department at Fernandez. She is a dancer. So, these type of activities, we keep doing it regularly. And our blood pressures are absolutely under control. Dance is something which involves all the muscles, heart and the mind. And when these things are tuned, the blood pressure automatically settles down. These are the ways of managing the pre-hypertensives, the stage 1 also. I am stressing upon because stage 1, you may require 1 or 2 drugs. By practicing these things, the pill burden can be reduced. So that way, you are indirectly contributing to the preventing or promoting the disease or progressing the disease. Music is the one which I practice. I'm a musician too. So, some of the observations which I have started off as a trial, I'm just opening the things to you. It is swara specific, means the note specific. It is the combination of different notes, the ragas, which is highly selective. Just trying to open. I think you can hear this so-called shruti. My laryngeal muscles are under control. My thoracic muscles, both the intercostal muscles as well as the muscles and lungs, are brought under control. It is the push and the pull of the autonomic nervous system and the release of the endorphins which contributes to the drop in the blood pressures. I have good number of pre-hypertensives who got incorporated voluntarily, whose blood pressures were brought under control with the use of specific notes and ragas. Some of the ragas, I think you are very familiar. If I talk in a Carnatic language, Kamas raga, Kiravani raga, and Kalyani raga. These are all the ragas or the different combination of notes. To put you to the film music. तेरे मेरे मिलन की रहना हो तेरे मेरे मिलन की रहना. This is based on Kamas. Sachinda has composed it way back 50 years ago. Tere mere milan kiye rehna. Even the lyrics are like that. Start listening to these type of compositions. Your blood pressures would touch normal. And of course, meditation. Need not be a singer or a musician. Having a keen ear is more than enough. You start practicing meditation, any form of meditation. It cools your mind and body. There is one note. Loka samastha sukhino bhavantu. Sarve jana sukhino bhavantu. Om Shanti Shanti Shanti. This is the Shanti mantra which advocates the wellness for all. And that is the theme for today's program. Thank you for the patient hearing. Questions from the audience? You're welcome. It has been tried, sir. I think even I am not aware, but it is supposed to stimulate the peripheral nerves. And again, through the ganglia, again it is the autonomic nervous system which plays an important role in the connecting. More than this, I think I require the help of the acupuncture experts who are here.
Personal experience, and if doctors are very much interested, such specialists are there, they can introduce so that no one can beat allopathy in the future. Thank you.
My request to Ramkishanji is, I have started the trial, sir, with ethical committee's approval. I am using music regularly in a certain section of outpatient basis, and my plans are to extend this to the second level, that is catering to the pre-op wards, the post-operative units, the ICU units, terminally ill patients, and finally, I think I'm going to go into the labor wards also. The trials are on at Apollo. Just wanted to. Thank you.